Good morning. I'm Dr. Nicholas Aloy, your host on PI Today. Welcome to another episode. I've brought you a very exciting physician today to discuss injuries, things that happen in the personal injury world, and how to treat them, how to diagnose them, and to start getting your clients and patients better. Today's guest is Dr. Charles Ananian. He is a podiatrist, a DPM, a doctor of podiatry medicine, and he comes to us to bring us some knowledge about the world of podiatry. Doctor, welcome.
Thank you. Thank you very much for having me.
It's a pleasure. So, Doc, tell us about your schooling. Tell us about your background. Let our audience know what podiatry is. Some are very familiar with it. Some are not. And how it interfaces in the world of personal injury.
Absolutely happy to tell you about it. Podiatrists, undergo similar education and training to allopathic schools or allopathic doctors. We do, 4 years. You need to get a 4-year degree at a university. I went to UCLA for 4 years, got a degree in biology. I did 4 years of podiatry school at the California College of Podiatric Medicine, and I did a 3-year surgical residency program at UCLA, all of UCLA, and the VA West LA.
Well, that's
And that's where
wonderful.
we get our surgical residency done. There are some fellowships available. They're kind of up and coming for reconstruction and things like that. But any good program, like the program I went to at a county hospital, we saw a lot of different pathology and did plenty of cases. And for us, a fellowship wasn't needed. So,
That's
yeah,
fantastic.
yeah.
In podiatry, what are some of the things that you guys do and the misconceptions as far as I want to know the difference between an orthopedist,
Sure.
extremities, and a
Mm-hmm.
podiatrist?
Yeah, so I think the difference there is our program, and this is the reason why I chose it, is accelerated just for foot and ankle. So in California, anything below the knee that has to do with pathology for the foot and ankle is our every day, all day. That's what we do. There's a lot of orthopedists that are fellowship trained in foot and ankle surgery. They do a 4-year residency in orthopedics, then maybe a 2-year residency in foot and ankle. A lot of research. We did research at my program as well. But I don't. I guess the main difference is that we're definitely just doing foot and ankle work. A lot of the orthos will do hips, knees, elbows, and foot and ankle as well.
So
So
basically, you super specialize
right,
below the knee.
right, right,
So calf, ankle,
right,
foot, and toes.
right. And
Okay,
and that's apparent in our training because we'll do gross anatomy in the first year of our training, and we do a separate 1 year in lower extremity anatomy. So we're delving into the lower extremity, 1,000% compared to other schools.
got it, got it.
Yep.
So, tell me about. We were talking before the podcast started, which is kind of exciting and not a lot of my viewers don't know this, but tell me about some of the nerve issues that can be misdiagnosed.
Sure.
What type of injuries?
Hmm.
Something like CRPS.
Absolutely.
What are some of the treatments and diagnoses that you do?
So fortunately, I was mentored by Dr. Gabriel Halpern, who you know very well, recently retired. But when I came to the practice, he was getting training by Lee Dellin, who kind of pioneered nerve surgery, and lower extremity nerve surgery as well. He was a triple boarded plastics ortho gen surge guy out of Maryland, and Dr. Halpern did a course with him, surgery with him, and that kind of spread to a fellowship program called the Association of Extremity Nerve Surgeons, which I myself is a fellow of, and that entails 1 week, 2 week seminars a year. We submit our cases, they scrutinize our cases, so we are fellowship trained in lower extremity nerve surgery. So what does that entail? So most podiatrists are well versed in let's say tarsal tunnel release, or which is the release of the nerve in the medial ankle, and Morton's norma, which is another nerve in the foot, the third interspace nerve. Most podiatrists are comfortable doing that in their training. When we get more proximal into the superficial peroneal nerve, the deep peroneal nerve, even common peroneal nerve releases, that's where the extra training kind of came in, and that's why we decided to do that, so we can be well trained and versed for our patients who need that. So what happens a lot of times with injuries, crush injuries, rotational force injuries, these ankle injuries that patient had an ORIF, but they still have burning and things like that. They'll get the hardware removed and then they'll come to us because we're like usually the third opinion because somebody along the line recognized that maybe this is a superficial nerve injury. And, when you have a strong rotational force, there's a traction mechanism that tugs on the nerve, and that'll create a Sneddon type 1 injury. Sneddon's the classification for nerve injury. 1 being a nerve bruise, 4 being transection of the nerve, and the nerve's not coming back. So there's, 1, 2, 3, 4 in that classification. So a lot of times patients will have a bad rotational injury, a bad ankle injury, or the bones, the cartilage is repaired. They have this chronic pain, 2-3 years going down, nothing's working. Sometimes, unfortunately, they get labeled as drug seekers or malingers, but, we see them, they have real pain. We'll do a diagnostic nerve block into the common perineal nerve. For 2 hours, their symptoms are completely resolved. And that's a patient that we can, confidently say we can help with a common perineal nerve release.
And that includes, that's surgery.
That's surgery.
Basically
Yep.
a decompression.
Yes, a nerve
Right.
decompression. So we all know about, carpal tunnel for the wrist.
Sure.
This is kind of a tarsal tunnel would be for the ankle. It's the same nerve release where the nerve is swollen and it's permanently swollen because of the injury. It's not going to get better after 6 months if it hasn't improved. That nerve swelling is there for life. So basically what we're doing is releasing the ligament that's pinching that nerve that you can live without, that ligament. And the nerve's fat and happy. That's what we like to call it. You can see too, intraoperatively, the nerve's kind of pale white, not yellow. You don't see any vasovasorum, the tiny arteries feeding the nerve. You don't see them visually. You do the release. We protect the nerve. We do it under loop dissection, 3 times magnification. You cut the ligament, and all of a sudden the nerve comes back to a bright yellow, glistening yellow.
Amazing.
You see the injection right away. Yeah, and it's we don't even block them. We in the recovery room, the patient's like, man, this is
Amazing.
night and day difference. So
And for everybody out there, when you think of decompression, just what we do in our field, what we talk about is like micro decompression for the spine.
sure.
So for my audience to kind of remember this is very simple. It's taking the pressure off the nerve. You're decompressing the nerve, and a lot of these crush injuries can be explained as if somebody has a patella fracture, knee fracture, a piano falling and fracturing your tibia, basically breaking your leg, right? And the nerve gets affected. And there has been times that this shooting pain or burning, doc sometimes gets misdiagnosed as some sort of sciatica, but
Sure.
it's from the knee and
Right.
below, right?
Right. At that point, we're going to do our workup. By that time, the patient's probably had an MRI that's negative or a nerve conduction study that's maybe positive for lower extremity, pathology. And that's like I said, we'll also do some diagnostic blocks, kind of see which nerve is affected. We'll do the common perineal nerve, come back in 2 weeks, keep a little diary for that day. We'll block the superficial perineal nerve, see if that is involved, deep perineal nerve, see if that's involved. And then we kind of do almost like a nerve mapping. And we have some level of confidence saying that if we just decompress the common perineal nerve, the patient's going to have some resolution of symptoms. And these aren't, huge debilitating surgeries, right? The nerve's kind of right below that ligament, and they're maybe off their foot for a week or 2 to heal the wound, and then maybe some physical therapy, some neural gliding, and they're out the door.
That's right.
Yeah.
And as you mentioned, Dr. Halper, and I remember when I was practicing, I would refer, and I've seen it firsthand. It really, truly changes these patients' lives, these people's lives, because they go through the system being misdiagnosed. And what Dr. Ananian is bringing us as a podiatrist is something very, very super specialized, where I've misdiagnosed it till I was educated about it. I always thought it was nerve pain from the lumbar spine, some sort of herniation, but that's how knowledge gets passed around. And also, how about ankle fractures? Stuff that we see in the personal injury world, slip and falls. Again, something falls on you. What do you do for those?
Sure. I mean, for us, ankle fractures, slip and falls with ligament damage are our bread and butter. It's something that we do on a weekly basis. there's a new procedure for lateral ankle ligament damage. There's a stabilization procedure that was really reserved for athletics and professional sports called internal brace. That's kind of changed the dynamic where in the old days we would open up the lateral ankle and basically imbricate the ligaments that were ruptured in the capsule, and that worked, but it was almost too stiff. It wasn't an anatomic repair. So a couple of companies come out with an internal brace, which is two non-metallic absorbable implants. One goes in the fibula, one goes in the talus. They have a really good guidance system, so it's not a huge open wound, and that restores the stability from the lost, anterior talofibular ligament, calcaneofibular ligament. We replace the stability there with those devices. So for ligament ruptures and things like that, it's kind of been a godsend for the patients and for us. We're getting really good results with that. Obviously, we do our fair share of open reduction internal fixation of ankle fractures, trimalleolar, bimalleolar, and things like that. We also did some extra training with total ankle implants. There's one particular one that I use. It's called the STAR implant, because you get to keep all planes of range of motion. It's one of the only ones that it's a mobile bearing, polymer that allows for sagittal motion, and most of the other ones kind of only keep you in one direction. So we will do a lot of those for some cases, again, that are older cases where the patient had an ankle fracture, car accident, slip and fall, 3, 4, 5 years ago. They're coming in with, a really bad joint for post-traumatic arthritis. And that'll be a good candidate depending on their age, where before these products came out, before these implants came out, they would go to an arthrodesis, which obviously leaves you with no range of motion and it's debilitating. You can affect the knee and the hip after that. So what we do now is a total ankle replacement, and that's, again, a game changer for these patients to
And are
keep
these
them
outpatient surgeries
Sure.
or
Yeah.
inpatient?
We definitely do these outpatient. It's
Okay.
with the guidance systems that they have and the implantation they have, it's an hour and a half, 2 hour surgery. It's not it's
Got it.
nothing too major.
And you talked to me a little bit about wound care, and
Yes.
this is really important because we sometimes don't have very healthy patients or clients.
Right.
They could be diabetic,
Hmm.
they get an injury, they might need to be amputated,
Mm.
depending on their injury. If they might got an implant from a prior physician in the emergency room, it could be infected.
Hmm.
So tell me about your wound care, amputation, stuff like that.
Sure. Me and myself, I'm a co-medical director at two wound care hyperbaric centers in Los Angeles and one in Apple Valley as well, where we combine, local wound care, skin substitutes, advanced healing modalities like wound vac, stem cell therapies, and things like that with hyperbaric. And hyperbaric, if for the audience, is a clear chamber. Patient goes in for about an hour and a half treatment. We put in oxygen at 2 atmospheres of pressure, and that does two really good things for chronic wounds. First, it stimulates the microvasculature to grow across the open void, and it stimulates the bone marrow to secrete and fabricate white blood cells. So you're literally fighting infection from the inside out. For patients who have osteomyelitis post-op and things like that, or post-injury, or a wound that's not healing, it's really, night and day difference with what hyperbaric can do. And even I was skeptical in the beginning, because we didn't see that in our training. And then, I got involved with the wound care centers, and I'd see a patient, I'm like, man, I'm sorry, we're probably going towards amputation. Their MRI lights up with the osteomyelitis everywhere. Anything we can do, I said, okay, we'll do a Hail Mary pass. We'll put you in the hyperbaric chamber, but it's not looking good. And they come out of there in 6 weeks, and there's no osteomyelitis. It's amazing.
Amazing.
Yeah, so it's really opened my eyes to different
So,
levels.
so even if from the knee below, if you have a burn victim,
Sure.
right?
Yeah.
That's wound care. Hyperbaric
Definitely.
is
Yeah.
absolutely
Yeah.
needed. So, Doc, what locations do you have? Where do you practice?
Oh, we're they like to say I'm everywhere. So we have a big group. There's 5 doctors in our group, and I myself, the main office is in East Los Angeles, kind of a mile and a half east of downtown. Got a big facility, 10,000 square feet.
Wonderful.
We have satellite offices in Panorama City by Mission Hospital, Santa Ana, Lancaster, Claremont, and then I myself go to Apple Valley to attend that wound center up there in near Victorville. So
That's
yeah,
great.
we're kind of all over. Yeah.
Thank you so much, Dr. Ananian, for being here today. So, for everybody out there, crush injuries, knee below, podiatry, Dr. Charles Ananian. And I thank you for being on the show.
It's a pleasure, Dr. Nick. Thank you.
My pleasure. Thank you.